بسم الله الرحمن الرحيم. النهاردة هنتكلم على specific urinary tract infection. We'll talk about the urinary tuberculosis and urinary schistosomiasis with the urinary tuberculosis. What is urinary tuberculosis? We'll talk about some history of this disease. It was first known as a disease of consumption because it has been observed in humans for over than 70,000 years. It was common disease in Egypt around 100 BC, and during the 1700s, the infection reached epidemic proportion in Europe. In 1882, Robert Koch discovered the cause of the tuberculosis with the tubercle bacilli. So what about the epidemiology of this disease? We will talk about the incidence. The WHO estimates that 1/3 of the world population is infected with TB, and this is a very huge number. Also, from 8 to 10 million new active cases of TB each year. In the United States, the number of disease declined annually until 1985, but it started to increase again. Why? Due to the presence of AIDS, immigration, and the neglect and deterioration of the public health infrastructure in the United States. So what about the transmission and development of the disease? As we all know, transmission of the TB is done by inhalation of droplet nuclei which reach the pulmonary alveoli. In addition to either laryngeal or cavitary pulmonary TB, the sputum contains up to 100 bacilli per milli. Genitourinary tuberculosis is caused by metastatic spread of the organism through the bloodstream during the initial infection. This means that the urinary tuberculosis is a secondary to pulmonary TB. So where is the primary organ in the nervous system? It is the kidney. The kidney is usually the primary organ infected in the urinary disease, and other parts of the urinary tract become involved by direct extension. The initial infection occurs in the renal cortex, where the bacilli can remain dormant within the glomeruli for decades. This dormant infection then becomes activated due to failure of the local immune response. So what about the immunology and the pathogenesis? The development of the disease, as we said before, depends on the interaction between the pathogen and the host immune response. The Mycobacterium tuberculosis, it is an intracellular pathogen which can evoke both humoral and cellular immune response by interaction between the T lymphocyte and the mycobacterial antigen to proliferate and generate cytokines which already activate the macrophages to be more bactericidal. What's the clinical features? The incidence of the disease as regards the age, it is from 20 to 40 years, male to female. Male is more than female by 2 to 1. It is very uncommon in children below 5 years. Why? Because the symptom of renal tuberculosis needs from 3 to 10 years to be manifest after the primary infection. What is the symptom? Any symptom of the urinary system can be the urinary tuberculosis. We have frequent painless micturition, we have urgency, we have sterile biuria, we have frank hematuria in presence of about 10% of patients who have renal or suprapubic pain, renal or urethral colic, recurrent cystitis, which is a warning sign of urinary tuberculosis. What about the first organ infected in the urinary system, which is the renal tuberculosis caused by activation of a prior blood-borne renal infection? The organism in the kidney settle in the blood vessels, usually these close to the glomeruli. What is the stages? We have 4 stages. Stage 1, which is TB of the kidney parenchyma, which is start as non-destructive form. Stage 2, which is TB papillitis. Stage 3, which is cavernous TB. Stage 4, which is polycavernous TB, which is causing widespread destruction of the kidney. The granuloma of the TB consists of Langerhans cells, lymphocytes, and fibro. What is the cause of the disease? The cause, as we said before, depends on the virulence of the organism and the resistance of the host. The healing process results in fibrosis of fibrous tissue deposition and the calcium salt deposition, producing the classic calcified lesions. There can be extensive calcification and fibrosis of the parenchyma, which is called autonephrectomy. The mycobacterium can remain dormant in this calcification for many years. So what about is infected by direct extension from the kidney and leads to fibrosis and stricture formation. The most common site of the affected part of the ureter is the uretrovesical junction and less common the middle third of the ureter. The uretrovesical junction is usually less than 5 centimeters in length, but rarely the whole of the ureter is involved, and the kidney show extensive disease and is often non-functioning and calcified. This is an IV view showing a section just a third of the left ureter. What the bladder are also secondary to renal tuberculosis. The earliest form of the infection starts around one or another urethral orifice, which becomes inflamed and edematous. As the area of mild inflammation progresses, granulations appear and may completely obscure the ureteric orifice. Tuberculous ulcers, it is rare but can appear at any part of the bladder. Occasionally, the whole bladder is covered by inflamed velvety granulations with ulcerations. If the disease continues to progress, the bladder wall starts to be fibrosed and to contraction occur, and this leading to small capacity or reduced capacity of the bladder and dense fibrosis in the trigone, which is causing what's called golf hole appearance of the ureteric orifice. This is the picture shows that the extensive tuberculosis of the kidney and ureteric calcification and stricture formation causing what's called autonephrectomy. In picture number B, this is acute inflammation of the ureteric orifice and around the ureteric orifice. In picture number C, which shows tuberculosis and tuberculous granulation of the bladder, acute tuberculous ulcer in picture number D. What about the mycobacterium? We have 4 types of Mycobacterium tuberculosis, which is called Mycobacterium complex, which is composed of Mycobacterium tuberculosis, Mycobacterium bovis, Microti, and africanum. Mycobacterium tuberculosis is the cause of most human disease, and the humans are the only reservoir for this. When we do tuberculin test, which is intradermal injection of PBD, purified protein derivatives of tuberculin, which cause inflammatory reaction, which develop at the site of the injections and reach its maximum appearance between 48 hours to 72 hours. This reaction consists of central indurated zone surrounded by an area of erythema. It is assessed by measuring the diameter of the indurated area, but this is not specific test because anyone has a BCG vaccination can do this, but it is not a specific. That's why we say that the tuberculin test is a good negative test, but not a good positive test, because if it is good negative test, this means this person has no TB before, but if it is positive, it might be from the BCG vaccination. So when we start to do urine examinations, urine examine for red blood cells, leukocytes, and the pH and the concentrations. Secondary bacterial infection can occur in about 20% of cases. Strawberry, which is the pathognomonic picture of TB, as we do routine culture and the culture coming out with no growth. This means that the organism is not present or cannot be cultivated in ordinary media. 50% of patients will have also microhematuria. We do culture for the TB. We need to take from 6 to 8 weeks because Mycobacterium tuberculosis is a slowly growing organism with a doubling time of about 15 to 20 hours. The organism is intermittently excreted. Therefore, 3 to 5 consecutive early morning specimen of urine should be cultured. Each specimen should be inoculated on Levenstein ginseng culture medium to isolate the Mycobacterium tuberculosis. But recently, we can do PCR, which is specific for TB. So what about we can do plain radiograph or plain QB? We can see the calcification in the renal parenchyma, and there we have to differentiate between calcification and stones. Stones mean calcification within the collecting system, but renal calcinosis means calcification within the renal parenchyma, as in this picture. This is a picture of the small dots of calcification in the renal parenchyma. We can do ultrasound, which has a limited value, but it can be used to monitor the size of the kidney lesion during chemotherapy or to monitor the volume of the contracted bladder during treatment. How about intravenous urography? It was the gold standard in the diagnosis and treatment and follow-up of patients with renal tuberculosis, but it is recently replaced by the CT. The IVU provides functional information relating to the ureteral peristalsis and the length of a stricture, particularly at the uretrovesical junctions. IVU show distortion of the calyx, ureteral dilatation, rigid fibrotic ureter with multiple strictures, and the cystographic phase of the IVU, the bladder may be small and contracted, which is called thimble bladder, or irregular with filling defects and the bladder asymmetry. This is an IVU which show occlusion of the upper calyx. It's not present, and here it is not appearing in this site, as this arrow shows no upper calyx. In this arrow, we see that this cystogram portion of the intravenous urogram in a patient with left renal tuberculosis. Notice the contraction left side of the bladder, which is second to fibrosis in this area, as the arrows show. In this area, it is called lakes of dye, which is a chronic pyelonephritic kidney, all destruction of the renal calyces and the parenchyma, and there is no definitive upper or middle or lower calyx. It is only lakes of dye, which is seen in severe calcium and parenchymal destruction by TB. The gold standard is the CTU, which is replacing the IVU in imaging modality of choice for diagnosis and evaluation of genital tuberculosis. We can see the calcium abnormalities, we can see hydronephrosis, autonephrectomy, amputation of the calyx, urinary tract calcification, and renal parenchymal cavity. In this CTU, we can see here in the left kidney, there is a small atrophic kidney with dense calcification here. But cystoscopy and biopsy, cystoscopy is rarely indicated in the diagnosis of genitourinary tuberculosis. However, cystoscopy and biopsy is usually necessary to rule out malignancy, and it is not advised before the initiation of medical therapy. How about retrograde pyelography? In cases where the kidney is obstructed and I cannot assess the function of this kidney, I do what's called retrograde pyelography. I through the cystoscope or ureteroscope, I can pass a ureteric catheter to the kidney. From this catheter, I can take a urine sample and do culture sensitivity, and I can select creatinine clearance from this kidney to see the actual function of this kidney and to measure what I will do with such renal units. In this kidney, through the cystoscope, I can do what's called percutaneous antegrade pyelography. Through ultrasound guided needle, I can put a catheter in the collecting system, and also I can take a urine sample, and I can do culture sensitivity, and I can see the aspiration of the content of the renal pelvis and see the actual function of this renal. Arteriography, radioscope scanning, or magnetic resonance are rarely indicated. They have very little application in the management of genital tuberculosis because they do not provide additional information over the other imaging modalities. So what about the treatment? We have a medical treatment, which the INH, it is a bactericide at high concentration, but it is hepatotoxic. Rifampicin is also hepatotoxic. Streptomycin, which is ototoxic, and we have barzinamide and isambutol. About surgery, what is our only and our goal from the urology? We usually deal with the complications. We can do nephrectomy, which is indicated only in non-functioning kidney with or without calcification, extensive disease involving the whole kidney together with hypertension and ureteral obstruction, or if there is coexisting renal carcinoma. But before doing nephrectomy, I have to look to the other side and be sure that the other side is good and functioning. We have partial nephrectomy, or what's called nephron sparing surgery, which is indicated if localized polar lesion containing calcifications that has failed to respond to treatment after 6 months of intensive chemotherapy, or if there is an area of calcification that's slowly increasing in size and is threatening to gradually destroy the whole kidney. What about the reconstructive surgery, which is done for the ureter and the bladder? We have a stricture ureter, which is usually in the lower third ureter. So if the length of stricture is short, I can do Endoretrotomy. What's the meaning of endoretrotomy? I can go by the ureteroscope. I can go through the ureteroscope and cut this structure from inside, which is called endoretrotomy. But if it is failed, or if the structure is lengthy and the length of structure is too much, I cannot do the endoretrotomy and do what's called reimplantation. I remove all this structure part of the ureter and reimplant the ureter again in the bladder, which is called reimplantation. But if the distance is so lengthy and the ureter cannot be reached to the bladder, I can do what's called Boire flap. I use a part of the bladder, making it like a tube, and put the ureter in this tube. If the bladder is not healthy and I can do this for the bladder, I can do what's called replacement. Replacement means that takes this part of the ureter out and put part of the intestine in between. And the most common part used is the ileum, which is called aerial ureteral replacement. After finishing the ureter, look for the bladder. If the bladder usually it's a small size, if the bladder size is not so contracted, I can do what's called auto-augmentation. What's the meaning of auto-augmentation? Auto-augmentation means that I augment the bladder from itself. The bladder, as we know, is composed of serosa, maciliosa, and the mucous membrane. I do serial cutting, radial cutting through the serosa and the muscle, leaving the mucous membrane to herniate between these incisions, making what's called iatrogenic diverticulum, which increase the length of the bladder. But if it is failed, or if the bladder is not completely healthy, I can do what's called ileal cystoplasty, means that taking part of the ileum and putting to the bladder to increase the size of the bladder. But if the bladder is so simple and cannot be do augmentation, I remove all the bladder and do what's called urinary conduit, which take part of the ileum and put the ureter in one end, at the other end it's put in the skin, which is called a urinary conduit diversion. But if the patient is healthy and is a young age, I can do what's called orthotopic new bladder, where the bladder is taking out and I take the part of the ileum and fashioning it like a bladder, and they re-implant this part of the ileum to the urethra as the functioning as a new bladder. That's all about the tuberculosis, and now we'll start for the urinary bilharziasis or urinary. This is a beautiful flow with schistosomiasis, which is a chronic disease caused by schistosomes, a genus of parasitic trematodes. The bird adult male and female worms cohabitate the venous plexus of the abdominal fissura, Schistosoma mansoni and javonicum, which is present in the mesenteric veins, leading to what's called gastrointestinal or hepatic disease. Schistosoma hematobium worm bale, which is present in the periphysical venous plexus and causes urinary schistosomiasis. So, what about the Egyptians? Also, the Egyptian physician in the 12th dynasty recognized hematuria as a cardinal sign and symptom of the disease. Theodore Bilharz, which is a German pathologist, was working in Cairo in late 1800s, the first who first described worm bears in the mesenteric vein. And this is a very good part. I saw it, and where the Egyptians think that the human male should have a menstruation like female. Why? Because he has to take the infection from the river. If the male does not menstruate, means that he is sick, and they have to return him to the river Nile to be infected with the bilharziasis to start to hematuria, which is the male menstruation is hematuria. What's about the biology? The adult worm, which measure about 1.5 centimeter in length, present in the vesical and pelvic venules and lay eggs from about 200 to 500 eggs per day within the venules of the human host. During the estimated life of the worm, which is about from 3 to 6 years, a single worm pair can give up to 250,000 to 600,000 eggs through their 20% of these eggs only cross the lumen of the hollow viscera, which is they late and are excreted in urine. But 80% of these eggs escape into the bloodstream and start to microimply of the microvasculature of the lung, flavor, and the other sites. And this is the main problem of all eggs. going out of the human body, there is no complication will occur. But due to retention of these eggs in these viscera, which causing dense fibrosis and calcium deposition, which causing all the complication of the bilharziasis. The hematobium eggs is ovoid and terminally spent. Eggs maturation begins in utero from a single oocyst and it continues for several days until the meracidium form. Mature meracidia remain viable within the eggs for less than 3 weeks, and if not excreted into water within that period, they die and the eggs. On deposition into fresh water, the meracidia emerge and enter the snail, which is called Burinus truncatus species, to produce sporocysts. Each meracidium produces from 200 to 400 cercari. These cercaria escape into surrounding fresh water. The cercaria moves through the water to find the once the penetration, the cercaria loses its tail outside and it becomes what's called schistosomulum. So schistosomulum means cercaria without tail. This schistosomulum begins its migratory growth, pairing, and maturation process, which in Schistosomium may require from 80 to 110 days. Then start to lay eggs and continue its life cycle. So what about the epidemiology? At the 200 million person affected with schistosomiasis, 80 to 90 million are infected by Schistosoma hematobium, 10 to 40 million persons have obstructed uropathy, and other complications secondary to their disease. Transmission of Schistosoma hematobium occurs in 53 countries in the Middle East and in most of the African continent. In Southeast Asia, the disease is found in Yemen, Saudi Arabia, Lebanon, Syria, Turkey, Iraq, and Iran. So what about schistosomal disease? Results directly from the granulomatous host reaction to schistosomal eggs. The host responds to eggs antigen by forming granulomas around the eggs, which is T-cell dependent. Viable adult birds sustained egg laying and a vigorous granulomatous host response characterized active urinary schistosomiasis. So grossly, these areas of granulomatous inflammation result in large, bulky, hyperemic and bulboid masses projecting into the lumen. Microscopic examination of these bulboidal masses show that bulboid patches consist of granulomas separated by edematous granulation tissue diffusely infiltrated by eosinophil lymphocyte and plasma cells. So what about schistosomal polyposis of the urinary bladder consists of multiple large inflammatory polyps and is related to heavy localized egg burden during the active stage of the disease. But after the egg laying then ceased, entrapped eggs are destroyed or calcified and the inflammation decreases, being replaced by fibrous tissue to produce what's called sandy patches, which is characteristic for the chronic urinary bilharziasis. As we see this picture, we see a cystoscopic appearance of the common bilharzial lesion in the urinary bladder. We have A, bilharzial pseudotubercle, we have B, bilharzial sessile masses, we have C, the sandy patches, we have D, which is cystitis cystica, and E is the malignant ulcer, and the F is the squamous cell carcinoma. So what is the schistosomal obstructive uropathy? Which is usually bilateral and asymmetrical. It may occur in the ureteral meatus. It can occur in the interstitial ureter, juxtavesical ureter, lower third, or pelvic ureter. This results in hydroureter and hydronephrosis. So what about the bladder cancer? In the setting of schistosoma hematobium, it has an early onset from the patient age is usually from 40 to 50. 6 to 9% are squamous cell carcinoma, 5 to 15% is adenocarcinoma. More than 40% squamous cell carcinoma associated with schistosomiasis are well differentiated, but most of these occur in the posterior wall, but some 30% about in the lateral wall. It's usually exophytic in 70%, but it can be endophytic in about 25%. So what we have the acute bilharziasis, which is called Katayama fever. It is characterized by lymphadenopathy, splenomegaly, eosinophilia, urticaria, and other manifestation of serum sickness-like disease. We have a chronic bilharziasis, which is characterized by classic clinical presentation of active schistosomiasis hematuria with terminal dysuria. Hematuria due to bulboid lesions lead to clot retention. We sometimes have hemospermia and also we sometimes have testicular mass. What about the contracted bladder syndrome during the late chronic active stage leads to deep lower abdominal pain, pelvic pain, urgent frequency, and sometimes incontinence. Chronic or recurrent urinary tract infections, which is usually called by Salmonella species, often associated with intermittent bacterial. What about diagnosis? We have a laboratory diagnosis of terminal spent eggs in the urinary sediment is a diagnostic for active schistosoma hematobium infections. But we have a serologic test which is called Western blot that is sensitive and specific for schistosoma hematobium. What about QB, which have a classic presentation of a calcified bladder which looks like a fetal head in the pelvis, which is pathognomonic of chronic urinary bilharziasis. As we see in this picture, the calcification of the wall of the bladder, which looks like the fetal head in pregnancy. We have abdominal ultrasound, which detects the focal thickening of the bladder wall and the polypoid lesions in the urinary tract. Also, we can take the hydroureter and hydronephrosis in the endemic area, and it detects heavily calcified patches. About the IVU, here we can diagnose the hydroureter hydronephrosis. We can see the non-functioning kidney, which is not visualized. We can see the urethral stenosis, bladder, and urethral filling defects such as polypoidal lesion or cancer. In this IVU, which of an Egyptian boy, shows scalloping of the bladder and the right lower ureter by polypoidal lesions, here as the arrow shows. What about the PCG, which is done for detection of the vesicular reflux, which occur about 25% of affected ureter? What about the treatment? Treatment in the form of praziquantel, which has a cure rate from 83% to 100%. What about surgical management, which is the main cornerstone of this lecture? Treatment of the complication, as we know, urology means the surgery of the complications. What's the complication? If you have the kidney is lost, we can do nephrectomy, but we need to see the other kidney, and if the kidney is good, we look for what's called nephron sparing surgery. When we talk about the stricture ureter, as in that is the tuberculosis, if the length of the stricture is short, we can do endoureterotomy, but if the length of the stricture is big, we can do what's called urethral reimplantation. If the distance is so huge, we can do what's called Boire flap or ileal replacement of the ureter. But we can see the bladder. If the bladder is too small and is contracted, we can do auto-augmentation. If it is failed or if the bladder is not good, we can do what's called ileal loop ileocystoplasty, augmentation of the bladder with the part of the ileum. And at the end, if the bladder is not good at all, we can do orthotopic new bladder from the ileum. And here is the part which is very important, how we treat the intractable bladder hemorrhage. Intractable bladder hemorrhage, we can treat it by cystoscopy, so we can do coagulation of the bleeding side of the bladder, but if it is failed, we can do open surgery, and we start to ligate of the internal iliac, which is the main blood supply for the bladder. We ligate one side. If the bleeding stops, it's okay. If not, we can ligate the other side to decrease the bleeding. That's all. Urinary bilharziasis, and thank you.